detector, or it could be a charged coupled device. So this what happens is this X radiation is converted into visible light, and this cesium iodide crystals which are present in this 2D detector converts this visible light, because they are photosensitive, and converts this visible light into electrical signals. So this is a process of CBCT. So these electrical signals are then transferred to the computer, or where certain algorithms and formulas are formed, and this is converted into a 3D volumetric imaging. So these electrical signals are converted into digital signals, and then it is the 3D volumetric construction is done. So this is the process of cone beam computed tomography. Yes, before going into cone beam 3D imaging, you should really know a few points about pixel and voxel. What is this pixel or voxel is? Pixel is picture element and voxel is volume picture element. The volume reconstruction performed by the digital system. The computers which we have is a digital system. Digital is nothing but it accepts data in the form of numbers. That is 1 and 2. So the volume reconstruction performed by the digital system is made like voxels. Like this is a pixel, and this the third dimension of the pixel, that is 3D form of the pixel is the voxel. And these voxels are known as isotropic when all the sides are equal in size. It is known as isotropic voxels, and this is a very important point, because like in CBCT all the voxels are isotropic, and which is a great advantage because it gives a very best spatial resolution, that is space resolution, where you can make real-time measurements or imaging. You can exactly measure the size of the tooth, or size of a root canal, size of the available bone present for implantology. All these things we are able to make because the voxels and CBCT are isotropic. And when compared to CT, the voxels are non-isotropic. That is, the X plane and the Y plane are equal in size, but the Z plane is not equal in size. So the radiation comes in X, Z, and Y planes. That is, it's more technical, but X is nothing but anterior to posterior relations, and Y is nothing but condyle to condyle, and Z is nothing but submental vertex. Each are perpendicular to each other, and this isotropic voxels gives us a very great advantage, and that is why we are able, that is why CBCT, like we can call it as a real-time imaging, where we can make measurements, and we can even check for the object alignment, which is not possible with computed tomography. The next thing is that once the images are captured by the CBCT machine, the three main processes which happen is acquisition, reconstruction, and display of the images. So image acquisition is made by the CBCT machine. It could be any machine, but the main part of this CBCT is that image acquisition by a very good machine which has a high KVP and which gives low radiation to the patient, so that the quality of those images depends upon the machine which we are using. And then comes the reconstruction process. For that we need a computer. As I already told, there are many number of raw data which has been created by this CBCT machine. The raw data is nothing but the 2D planar or cephalometric images which has been created, which has been converted into digital, and it is processed into the computer, and with certain algorithms, mainly it is the algorithm which is used is known as a Feldkamp algorithm, which then reconstructs into 3D volumetric images for us. And then of course the display part, where the image is displayed. Yes, Like after the reconstruction, the default screen which opens is an orthogonal slicing screen which contains the axial, sagittal, and coronal sections. These are known as multiplanar reconstructions, that is MPR. So once there is image acquisition, the computer reconstructs into multiplanar reconstruction where the axial, coronal, and the sagittal sections are made. In case of CT, the raw data which is formed by the machine is nothing but the axial sections. But in case of CBCT, it is a image which resembles a lateral cephalogram, and so that is what you have to know. And the main difference between CT and CBCT is that in case of computer tomography, there is slicing made first and then the images are put together. But in case of cone beam computer tomography, the raw data, the entire image is formed first and then the slicing is made. So this is the difference between CT and CBCT. So this is a default screen which will open. This is from a casting software, but there are many other softwares. Like basically, it will be like this. Like it will have an axial plane, coronal plane, and sagittal plane, and a 3D volumetric rendering plane will be there. And this is the screen which will open, and you will have all the you will have all facilities to make measurements or arch plans. And for implant measurements, all the tools which we use for these will be present on the left side. So apart from this MPR, that is multiplanar reconstruction, we see axial, coronal, and sagittal section. Is it only these sections we will be able to see? No, there are also other facilities or other reconstructions which we can make apart from these three basic images. So first is the acquired images go for this 3D reconstruction as axial, coronal, and sagittal, and this is known as the orthogonal view. And apart from that, you can also have multiplanar reformatted images, ray sum, and volumetric images. So these two are the volumetric images. This is known as in direct volume rendering and indirect volume rendering. So these two are the volumetric images, and this is the transverse section or the cross section which we use for implant measurements. So this is one other section that is we'll be able to access in this software. And apart from that, there is also Tmj imaging and also other cross-sectional views. So apart from the basic axial, coronal, and sagittal, we will be also be able to make these amount of images according to our need. So what is Dicom? Dicom is nothing but digital imaging and communication in medicine. So the data is in the digital form, and the communication between the computers takes place with the help of this language. So it is just a language, it is computer language. So any clinician who has a Dicom reader or a software will be able to access any three-dimensional volumetric images which he has. So it is a software where it reads all the 3D data. And it also controls a method of storing, and it is also helpful for transferring from one computer to the other, and it is also patient friendly. Like you can also, even if the patient has a 3D data, he can receive, if he has a Dicom reader, he can receive the 3D data and he can store it. Like this is the language which is used by the computers to speak among themselves. Next, coming to the field of view. Next, coming to the field of view. Field of view is nothing but the volume which we are going to radiate the patient. So whether it is small field of view, you need only one tooth to be exposed, or you need multiple tooth in the same arch, or you need both the arches, or it is a full facial, depends upon the need for the patient, depends on what pathology you're going to diagnose for the patient. So if at all, if you're going to check for a root canal, single tooth exposure is fine, because smaller the FOV, better the resolution of the image. So always I would recommend go for a smaller FOV if the other parts or other facial structures are not needed, and it will give you a better resolution, because when you go for a full facial, the resolution will be much lesser when compared to a smaller FOV. So the available FOVs are like localized region, approximately around 5 centimeters or less, and it is not usually used for a dentoalveolar purpose to check for the root canals or periodontium around the tooth. And then temporomandibular exposures also come under this localized region exposure. And then it single arch is 5 into 7 centimeters, either complete maxilla or complete mandible. Interarch is around 7 to 10 centimeters. For example, you can take both maxilla and mandible, and then there comes a maxillofacial region up to the nasion level, and then the craniofacial, where you can take from the lower border of the mandible to the vertex of the head. So these are the available FOVs, and all the latest missions provide all these FOVs. It is the role of the dentist who's referring the patient and also the radiologist to match to confirm the exact FOV which is necessary for that patient, and use it accordingly, so that we can have a better diagnosis with best resolution which is available. So now this slide will tell you about the differences between CT and CBCT, which is really necessary for us to know because we are going to work with it. Like conventional CTs are both hard tissue and soft tissue imaging. That we have to accept the fact that CBCT is not a soft tissue imaging modality. So whenever we think that apart from the hard tissues, we need a soft tissue examination for the patient, it is better to go for computer tomography. And then, of course, CBCT has better spatial resolution because the voxels are isotropic, but CT has better contrast to noise ratio is very less, and that gives you a better contrast resolution because of the shape of the beam. The shape of the beam in CBCT is cone beam, and we accept all the scattered radiation which also falls on the patient, and it forms really high noise. Noise is nothing but distortion in the images, and there is really high artifacts when compared to CT. So that is these two are the main drawbacks of CBCT as for now, because we are not able to see the soft tissues, and at the same time we are suffering from high radiographic noise and the artifacts, which is much less in CT. But when we think about these two things, I think we can manage these two things, because we are viewing structures which are very small, that we are viewing teeth and the structures, periodontium and the bone around that. I think we can compromise these two things, because it gives really less radiation to the patient, and of course it is very cheap, and it is accessible, very easily accessible. So these two things are the main drawbacks of CBCT. But the voxel sizes matters a lot. The size of the voxel in CBCT is submillimetric, that is, it is less than a millimeter, 0.076 to 0.4, which has a very, very increased accuracy and high resolution images. And that is why we are able to make measurements, which in case of CT, the voxels are anisotropic, and are at the same time the voxel size is large, and that is why the spatial resolution is very less in case of CT. And of course, you have to make the patient to in supine position, or in CBCT you can make the patient stand or sit according to the comfort. And as I told you earlier, the CT slicing technology is that it collects the axial slices, and then it reconstructs it, puts it together into a volume. In case of CBCT, we collect the data first, the entire data, and then we make slices. So this is more precise when we compare, because we can make slices according to our thickness, because we're collecting the entire data and then we are making the slices, and we can decide the thickness of the slices. So X-ray parameters at the same time, for CT, it is really high, which gives a high radiation to the patient. And of course, CT, I think everybody would have been exposed to CT during this COVID times for taking chest CT. And I think because the gantry moves each and every time into the the gantry, there's movement of the gantry each and every time, then there is slice by slice imaging by the fan shaped beam. But in case of CBCT, it is only one solid rotation. And of course, there is low image quality in case of CBCT when compared to CT due to scattering and secondary radiation, as I told you earlier. And of course, one more thing is that the bone density values which are mentioned is CT is Hounsfield, which is highly reliable. But in case of CBCT, it is not very reliable because of the cone beam. But however, it almost relates equally, and we have developed many units which are similar to that of Hounsfield units, which can match, and we have created a separate unit. So I think bone density is not that reliable in case of CBCT, but reconstructed images are not accurate in case of computed tomography, but we are precise in case of reconstructed images. So whatever reconstruction is made, either it's an axial or a cross-sectional view, everything is precise. Not only the primary image, everything, all the reconstruction is precise, and it's exactly the replica of the facial structures which the patient has. So CT slices, as I told you, you can see in this picture, CT slices are made like this. First the slicing is done, and then the reconstruction is done. So you can imagine, like, there is a loaf of bread which is already sliced, and there's another loaf of bread which is not sliced. CBCTs which is not sliced, and in case of CT, already there is slicing done in the loaf of bread, so it is all combined. So this is a difference between CT and CBCT. So I just want to tell you some of the about the CBCT mission. Just one slide about the CBCT mission, because you'll be able to know what all the present. Because in this mission, what I have put here is CAD Stream 9600 version. I think all the missions have this. Is nothing to do with casting, but still, like, it has an AI powered positioning, that is artificial intelligence powered positioning, which means that if you enter a patient's name and age, and it records the patient, and when you're going to expose the patient for the next time, it already sets itself to the parameters of the page of that patient which was exposed in the previous time, and that previous it has a memory, artificial memory, so that it can record those parameters. And you also have live positioning assistance, because once you set the patient and you come out and you expose the patient, you will know what if the patient is moving or not, and you will have a live positioning assistance, so that you can talk to your patient, don't move, or keep your tongue to the palate, or all these instructions you can give. You have video cameras and integrated retractable seat. CSMR is metallic artifact reduction. It has a technology where there is much reduction in metallic artifacts, and the stellar technology where 120 kV X-ray tube is present, where you can very much reduce the noise and the artifacts caused by the metallic restorations. And it has an intelligent filtration, very much reducing the exposure to the patient. You can take a full mouth exposure at 75 microns. And you can also have an option of low dose scout images, where you can just check whether the images are like correct, and then go for the real exposure. It is like pre-exposure images. So these are some of the technological advancements which is there present in the later CBCT missions, almost all missions. So what is that increase in kVp? I was mentioning about increase in kVp. If there is increase in kV, that is kilovoltage, there is reduction in artifact. Of course, the patient exposure is also a little higher, but still the artifact reduction is much higher when there is increase in KVP. And apart from that, you can also, apart from these advantages in CBCT missions, you can also have a superimposition of facial images, that some CBCT missions can take photographs of the patient, or you can take an image of the patient and then superimpose it with the patient's facial structures, and for soft tissue assessment and for orthodontic purposes, etc. And you can also take a 3D model scan of the patient, and which will be useful in guided implant surgeries and so on. And apart from that, you can even make a cephalometric analysis for ortho, and then you can do even an airway analysis where you have multicolored software, or which will be helpful to mark the airway, and it will be helpful to check for airway constructions in case of orthodontic surgeries. So these are some of the advantages of the CBCT missions. So coming to radiation, yes, of course, everybody is here is worried about the radiation exposure to the patient. According to AERB regulations, 100 microsieverts of radiation is even safe for the embryo, that is the pregnant women. So it's saying about the radiation dose which the patients receive for when they are exposed to a CBCT. For example, if you're selecting for a localized field of view, that is a smaller FOV, it is almost equal or less than that of a dental panoramic radiograph. And then even full, if you're going for about cone beam CT for a craniofacial, it is around 68 to 599 microsieverts, which is even 4 to 5 times less than that of a medical CT scan, which just comes around 2000 microsieverts. So that is a great advantage in the field of dentistry and maxillofacial imaging, where we are able to use our 3D volumetric imaging with very much low exposure to the patient. However, there are some caution which we have to follow. So do not use CBCT on patients who are about 5 years or less than of age, or 21 kgs or 113 centimeters in height. This is the protocol. So do not use cone beam imaging for routine or screening examinations. So if you have placed an implant and if you want to check whether the implant is in correct position, then go for it. Even if the patient is not having any symptoms, don't go for a CBCT. If the patient is not having any symptoms, better go for an IOP or an OPG. So for routine screening examination, just to check whether the position is correct, or just to screening purposes, please don't use CBCT, because it is an unnecessary exposure to the patient. And do not use where likely you feel that there is some soft tissue which is involved. In case of TMJ problems, okay, like if it is an osseous complaint, yes, fine. But if you think that there is some amount of musculature or soft tissue involved, please go for another radiographic examinations. And always follow the ALARA principle, that is as low as reasonably achievable, and also as low as diagnostically applicable and indication oriented and patient specific. That is what is for CBCT, ALADAIP. As low as diagnostically applicable means that if you feel that that image is going to improve your diagnosis and then serve for the patient, and it is indication oriented, depends on what indication you're sending, and patient specific. It's not applied for all the patients. Of course, you have to select your patient. So these are some of the cautions we have to follow while prescribing a CBCT for the patient. So coming to the advantages and the disadvantages, as I already told you, there are only advantages and very few disadvantages, like image noise and soft tissue contrast or artifacts. So these two are the main disadvantage of CBCT as far as I know. So on discussing of some of the artifacts, so these artifacts can be caused while exposing the patient. Like it could be due to patient movement, or it could be due to some computer algorithms or something like that. So some of the artifacts, I'll just give you example. You can see dark streak lines around the metallic restorations, and these are known as streak artifacts, which are caused due to undersampling. Undersampling is if the sampling intervals, that is, you know that we are sampling the data. Like if the sampling intervals of the raw data, it is a raw data is nothing but the lateral submetric images. That is the raw images which the machine provides. If the sampling interval is too large when compared to the speed of the rotation, if you think that the machine rotates faster and the sampling intervals are slower, and then these artifacts are caused. So this is an example of streak or artifacts where there is dark lines which are seen around the dark streak lines which are seen around the metallic restorations. So this is one more artifact. This is a ring artifact. You can see a ring shaped radio opaque line. You can see in this CBCT also. These are formed by poorly calibrated receptors. The receptor which is present, that is this flat panel detector. So nothing to do much about with our exposure. Sometimes it is not avoidable. So this is an example of aliasing artifact. You can see streaks here, dark line streaks, and also there is alternate white and dark lines which is radiating away. This is known as an aliasing artifact, and this is also caused due to undersampling. And this is an example of motion artifact. Usually in motion artifacts, you see double images. So either the motion of the patient can be either due to normal pathophysiological movements like swallowing, breathing, or the patient is not steady in the steady position in the mission. So because of that patient movement, and also when the tongue is not placed close to the palate, you will have a narrowing of the airway, and you may suspect it to be an airway constriction. So these are some of the examples of artifacts which we can get in a CBCT mission. And the most important artifact is a beam hardening artifact, which is a most prominent artifact which you see whenever you image a patient with metal restorations. Even if one restorations or two restorations, if the patient is wearing a bridge, you can see this beam hardening artifact. You can see this white arrow here in a 3D reconstructed image here. This is the beam hardening. It will be seen as both white and dark streaks, which will be present interdentally in between the metallic restorations. I'm not talking about these lines. These are streak artifacts, but I'm talking about the dark beam hardening effect, which is present in between interdentally in between the crown. So these are some of the examples of artifacts, and that is why I told that in case of CT, you have a specific whenever you are exposing the patient with metals, you have a specific tool where you can reduce your metal artifact reduction tool. But in CBCT, when you're exposing, it is not present. Maybe you have it in your software where you can reduce. Of course, with the latest advancements in the increase in KVP, there is much less reduction in the metal artifacts. Yes, now I've completed with my all basics of CBCT. What is the advantages, what is the disadvantages, and all the artifacts which are present. Now we'll be entering into applications of CBCT in dentistry. Of course, we all know that CBCT has revolutionized the maxillofacial imaging, and CBCT is now considered as the gold standard, and it should not be considered as a substitute for panoramic or conventional projection radiography, and it should be considered as complementary modality for specific applications. Now we'll be seeing the applications of CBCT now in each field of dentistry. Most commonly, we refer the patients for implants and impacted tooth, to know the position of the impacted tooth and for endodontic purposes. I think these three are the main reasons where we refer for CBCT. So this is a percentage of peripheral. So mainly first it is for the maxillofacial surgery. It includes the implants, and then for 25.6% to endodontics, and then 16.3% to implant dentistry alone. And then of course 11% for the orthodontic purposes. Now coming to CBCT in endodontics. Yes, endodontics, CBCT plays a very major role. I think we should tell like that. And it is used for detecting periapical, not for detecting actually. IOP is enough for detecting periapical lesions, but to know the extent and location and involvement and all those things. So to determine the origin of the lesion or vertical root fractures, to check for the canals, missed canals, to check for the quality of the obturation, to check for vertical and horizontal root fractures, working length measurements, and root resorptions, root angulations. So all these things, some of the applications of CBCT in endodontics. So now I'll be showing you the cases. Please just wait a minute. I'm just. Ma'am? Ma'am, is the screen visible completely?
Yeah, it's visible.
Ma'am, like, is there any students like who can like answer if I ask any questions, like they can comment in the comment section?
Yeah, most of the interns are there.
Okay, ma'am. Okay. If at all,
we'll see. We'll try to unmute them.
Okay, ma'am.
Okay.
Okay, this is an intraoral periapical radiograph of a root canal treated in crown restoration done in a premolar. You could see a periapical lesion. Yes, of course, this is a very high resolution intraoral periapical radiograph, and this serves the purpose. Everything is fine. There's a periapical lesion in a root canal treated tooth. So now, still the patient was having pain and a CBCT was taken. Like, now you will be able to know the real extent of the, you can just compare yourself. This is a sagittal section of the same tooth. Now you can be able to know what is the difference between this image and this. There is a wide extension, and also there is a black arrow which is clearly showing an extra canal, or it is a canal which causes this. So this is an advantage of CBCT. So in this radiograph, I'm not able to make out anything. This is an intraoral periapical radiograph. There is some widening of periodontal ligament space in the distobuccal root. And apart from that, I'm not able to, and there's some amount of bone loss here. It is a CBCT of the same case. So the patient was having chronic pain. And when you see the CBCT, you could see that there is a periapical lesion, and there is a breach in the floor of the maxillary sinus and causing some mucosal thickening in the maxillary sinus. Then one more intraoral periapical radiograph. Yes, like it was fine, but I'm not able to make out anything here in the periapical region. Like if anybody is able to make out anything, just kindly comment me. And when you're seeing the CBCT, there is some amount of periapical, small periapical lesion which is there, which is causing the pain for the patient. So I'm not telling that immediately if the patient is having pain, refer the patient for CBCT. No, it is not possible. So of course, in a clinical setup, IOP is a gold standard radiograph. You have to take an IOP. But still, if the patient, if you're not satisfied, and if the patient is not satisfied, and if the patient is complaining of chronic pain, and then you can refer the patient. So this is a case of fracture where this is an intraoral periapical radiograph. Yes, I'm able to make out a thin radiolucent line which is passing along the mid-third of the roots of 1-1 and 2-1. But still, when I take a CBCT, you could really see the extent of the fracture line involving each and every tooth. You can see the palatal and the buccal extensions. So this is what is the advantage of CBCT, where you will be able to make out the buccal and the labial relationships, and also in axial sections you'll be able to make out the expansion of the arches, and in transverse sections you'll be able to make measurements, and you'll be able to see each and every tooth separately. This is also an intraoral periapical radiograph. Here this is a which is of less contrast, so it's not we are not able to serve the purpose here. And the same patient on the CBCT, now you'll be able to make out the fracture. It is really unbelievable to see that whether this patient was exposed for CBCT, because you could very clearly see the fracture which is involving the tooth 2-1 and 1-1. This is a case of internal resorption as seen in intraoral periapical radiograph. You could see that there is a radiolucency in the cervical region in the pulp chamber in relation to 2-1. On taking the CBCT, now I doubt whether it is an internal resorption. Now you can see the difference between a 2D and a 3D radiograph. So this is what is the difference between, because of this overlapping of the structures here, we are not able to exactly make out the bucco-palatal relationship. Yes, CBCT plays a very important role in root canal morphology. Yes, like you can see in this picture, the root canal morphology of the tooth, which is very clearly, it is all CBCT sections. You can see that there is a connection between the buccal and the lingual canals. And you could see that, see in the axial, I mean, in the coronal section, there is only one canal, and when you come down to the middle third, it is 2 canals. And again, when you come to the apical section, it is 1 canal. So these kinds of root canal morphology will be very clearly made out with the help of CBCT. Next case, we of a missed canal, that is a middle mesial canal. You could see that in the top image that there is a, you can exactly see the position of the middle mesial canal, which is not possible with an intraoral 2D radiograph. So this case is case 1. You could see that 3:2:1 kind of root canal morphology, where there is 3 canals here, and then it is 2, and then it is 1. And it's case 2 here, you can see there is 3 canals. Here it is a lower molar, here it is 2, and again it becomes 3 in the apical region, and again it becomes 2. So this type of this is known as Virtue classification, and so this type of root canal morphologies can be made out very easily and very precisely with the help of cone beam computed tomography. So here is a lateral canal where you can, this is an intraoral periapical radiograph. So there is a periapical region. This root canal is very well done. So we cannot tell any problem here, but there is still a periapical lesion. And on a CBCT transfer section, you'll be able to see that there is this orange color arrow shows that there is a presence of a lateral canal. And one more case here, you could clearly see that this is a root canal treated tooth of the first molar, the upper molar, and this there is a periapical lesion. I could find some leaching of the endodontic material outside, but that is fine. And when you see a CBCT coronal section, you can see that there is a lateral canal as seen in this yellow color arrow. So these are some of the applications, like where there is persistent periapical lesions, you have to check whether there is an extra canal or a lateral canal. CBCT plays a major role. So this is a case one where there is a periapical lesion, and also there is some dense vaginatus here. So here there is a extra canal or a missed canal here. So radix centromolaris is nothing but an extralingual root, which is very commonly all endodontists will come across such cases, which is present in the lower molar. This is a cropped OPG section where we are not able to make out any extra root. I think I'm able to make out only 2 roots. But when you see a 3D reconstructed CBCT image, you can see that there is an extra root present, and that extra root also has a separate canal, which is present on the lingual side, on the distal side. So these some of the applications of CBCT. So in this case, yes, this root canal is well done, and this patient was referred for constant pain in relation to 4-6, and then CBCT was taken. Now you could see that there is a missed canal, which is very clearly seen in the sagittal section, and also you please note the root canal morphology of 4-7 here. Root canal morphology of 4-7. So it is like one canal which is dividing into 2, and then it is again merging into 1. So these are some of the applications in endodontics. One more case of untreated mesiolingual canal. This is a cropped OPG image, and I'm able to see some periapical radiolucency here, not very clear. And on seeing the CBCT, there is a mesiolingual canal which is not treated, and which is also causing a buccal cortical plate perforation here and a periapical lesion. Okay, this is an intraoral periapical radiograph, which is showing the separated instrument here in the apex. Okay, this separated instrument appears to be just outside the, it is not exactly sealing the apex, it is just in the periapical tissue. It appears to be like that. And while taking the CBCT, you could see that there is a root curvature, and this instrument is exactly present sealing the apex. So in this kind of cases, there will be an alteration in the treatment by the physician, because for this the treatment is different, and for this the treatment is different. I think for this need not remove the instrument at all. Okay, now you can see this is an interesting case. Like this case was referred, this is an intraoral periapical radiograph. This case was referred that the doctor was not able to remove the endodontic material from the root canal. So a CBCT was taken, and you see the endodontic material which is not present in the root canal at all. This is a very good case to explain the importance of 3-dimensional radiology. See where is the endodontic material present? It is, and there is also some perforation here. So one more case. This is an intraoral periapical radiograph taken. You see this A image, where you could see that I was able to make out some widening of periodontal ligament space around the here in the root surface. and this was treated with post, and when taking a CBCT, you could clearly see that there is a periapical lesion, and also there is some perforation of the post, which is causing that widening. So this type of post perforations or fenestrations and dehiscence can be easily made out with the help of CBCT. One more case of separated instrument where this was an intraoral periapical radiograph. You could see 2.1 and 2.2. 2.1 is having some periapical lesion, and 2.1 is also root canal treated. 2.2 is also root canal treated. I could make out some leaching of the endodontic material outside 2.2. And taking the CBCT, I really couldn't find this instrument in the IOP. Now, now I think it will be clear of what is causing this lesion in the periapex in relation to 2.1. So you could see the instrument here, and also this is the cross section of 2.2, which is showing the endodontic material. So one more case of separated instrument. This is a cropped OPG. And here you can see 1.5, there's a root canal treated tooth. I thought this gutta which is coming out is causing the lesion, but actually it is not. See the cross sections, you could clearly see that which is a file which is present exactly in the floor of maxillary sinus, and we were not able to, just because it was present palatally. This is a palatal side, this is a palatal root, and in this 2D radiograph it got overlapped, and we were not able to make out this instrument fracture. This is a broken file which we see in the axial section. So one more radiograph, one more OPG, which gives us example for 2D, difference between 2D and 3D. Now this patient was referred for periapical lesion in relation to 3 here, and also I was able to make out that tooth stump of 2.4 was also present, and there's a periapical lesion. Okay, fine, but see the 3D view. Where is the tooth stump present? It is actually away, and that it is almost present in the soft tissues. So this is a very nice case and importance of 3D radiology. So this is an case of calcified canal where 2.1 RCT was attempted, but I think there was a perforation because doctor was not able to make out the canal here. And this is a cropped OPG image. And on seeing the radiograph, now you can clearly see, but the canal appears as a faint, thin radiolucent line, which is present more palatal, but the opening was done more buccal. In axial section, you could see the opening of the canal in relation to 1.1 and in relation to 2.1 also. So this is a perforation. So this is the importance of 3D radiology. So now coming to cracked tooth. Here, the patient is an intraoral periapical radiograph. The patient was having constant pain in 5 premolars and the molars. Yes, but the patient was not very specific, and CBCT was taken. Now you will be able to make the small thin radiolucent line which is present in the palatal crown. So this is a crack in the tooth which is causing the pain. So this was also an interesting presentation, and this is an palatal canal which was missed. This is a case of palatal canal which caused doom effect or raising of the floor of the maxillary sinus upwards, which is also causing periapical abscess, and there is also some mucosal thickening of the maxillary sinus. I think the arrows are very clear here, and when I see the axial sections, there is a missed palatal canal which is causing the lesion. Next is an aberrant canal. Like in this premolar, there was opening done and was attempt for a root canal treatment was done, but the dentist was not able to move beyond this because there was 3 canals here. I think up to the middle third, it was only 1 canal, and after that, it divided into 3 canals. And at the apex also, there are 3 canals with 3 different openings. I think you can easily make out in this radiograph where there is up to the middle third of the root, there is a single canal, and which is dividing into 3, and it has 3 openings at the apex. So this is also one more example, endodontic application. This is a case of external root resorption, where in intraoral this is a cropped OPG image where we're not able to make out the resorption of the distal root, but in CBCT sections you can clearly see that there is resorption of the palatal distal root. So it's in one more case of vertical root fracture. Yes, with this intraoral periapical radiograph itself, we can suspect some fracture because there is some widening of periodontal ligament space, and there's a thin radiolucent line which is going here. But yes, still CBCT would be more precise in detecting the fracture. In this image, which is circled with red, you can clearly see the fracture line. And there is also some periapical abscess. This is a case of oblique root fracture. This is a coronal section and this is a sagittal section. So what is the difference is that in coronal section, even as I told you earlier, like 3D radiology is just stacking up of all 2D images. So even in coronal section, you're able to make only fracture which is horizontal in position. But when you see a sagittal section, you're able to make out the extent of the fracture, which is how palatally it is going, whether it is oblique or it is horizontal. So all the images put together, even when you have a CBCT, don't go just decide with only one single image, or only with axial or with a coronal section. Just go about with all the sections and then come for a decision. This one more case of internal resorption. This is an intraoral periapical radiograph where there is a root canal treated teeth.
The extraction over 7 or 8. 8 तो कुछ देगा yes ma'am detected है 8 root stump और slides सा है यहाँ पे remnant कैसी है एक्सेल लिया
Ma'am,
ma'am clinically root stump 7 8 no 7 areas like plastic areas है 8 root stump उसी रीजन में तो चीप पाएगा 8 तो कुछ देखते हैं इधर जो 7 मतलब आरएस लगा
ma'am,
7 का तो ग्राउंड स्ट्रक्चर देख
yes. Yeah, this is another case of internal root resorption where it was a root canal treated tooth in 1-1, and there is some pain in the tooth. So this internal resorption was not very clear in the intraoral periapical radiograph. You can also see the axial and the coronal sections. So this is one more case. I think I'm going very slow. So this is a case of dentoalveolar fracture. There was some partial avulsion of 1-1 and 1-2. This intraoral periapical radiograph, yes, I could make out some fracture line here in the apical root surface and also some avulsion which is causing the periapical lesion. And now see the CBCT sections. You could see that there is a dentoalveolar fracture. So in this intraoral periapical radiograph, you are able to make out the root fracture, yes, but which was overlapping on the roots. And now you can see that the fracture is actually dentoalveolar. I think you'll be able to make out the difference between now the 2D and the 3D now. Yes, this is a case of missed MB2 canal in relation to the upper molar, left upper molar, which is causing a periapical lesion, and it's also there's perforation of the floor of the maxillary sinus, and then there is some mucosal polyp in the maxillary sinus. It is odontogenic cause for maxillary sinusitis. So yes, this CBCT can also be helpful in detecting the length of the root canal. So studies have shown that the length of the root canal measured with CBCT it is almost matches the length of the root canal, which is done by conventional instruments. Yes, this is another interesting case where intraoral periapical radiograph showed some periapical abscess, and when taking a CBCT, you could see that the curvature of the root. You could see that there is a curvature of the root, and also there is some breach in the floor of the maxillary sinus. So, which was where definitely it is not possible to make out this curvature and the breach in with the help of intraoral periapical radiograph. So apart from endodontic, even to differentiate between non-endodontic and the endodontic lesions, CBCT will be of great use. It's a case of cementosis dysplasia where it was misdiagnosed as periapical lesions, and while the CBCT sections which made very clear of the differential diagnosis. Okay, now I'm finishing off with the applications of CBCT in endodontics, and now moving into the applications of CBCT in orthodontics. So the applications of CBCT in orthodontic is mainly for growth analysis to check. Mainly it was referred by the orthodontist to check the position in the relation of the impacted tooth, and also in cases of orthodontic surgeries to check for airway functions and check for the position of the impacted tooth or the position of the unerected tooth. So you can also an occlusal view of the what is the advantage of taking CBCT in orthodontics is that as an orthodontist you will take a lateral subchromatic radiograph, you could take an you have to take an OPG, and then you have to take an occlusal view in case you're going for an arch expansion. So all these radiographs are combined into one in case of CBCT. If you want to check for maxillary expansion, you go for axial sections. And yes, if you want to see for lateral subchromatic images, go for sagittal sections. And of course, the position of the impacted tooth and all the other tooth. So this is a one combined radiograph where the orthodontics need not take multiple radiographs for multiple purposes. And it's also, you can see this, apart from that, you can check for cervical vertebrae maturation. You usually take a hand wrist radiograph to check for the maturation. And this one CBCT image will comprise all these things where you can check for this. And if at all, if you're going for a mini palatal, if you're going to planning for mini implants or mini screws where you have to place. So for that, for exact location of placement of those mini screws also can be made with the help of CBCT. So in orthodontics, it is used for in patients with facial deformities like cleft lip and cleft palate like this. And you can easily check the occlusion and the position of the mandible, whether it is an whether you can check whether it is an orthodontic surgery needed or not with the position and the 3D images. And this is one example of orthodontic application where this is an OPG of the patient who is undergoing orthodontic treatment, and dentist was not able to move this premolar. On when taking the CBCT, you could see that there is a root stump which is hindering the movement of the premolar move forwards. So these are some of the examples which was referred, and I'm just sharing with you. And also in cases of temporary anchorage devices, to check for the position of where you have to place the temporary anchorage device, or once it is placed, if you want to access it, then you can go for a CBCT. See, this is one more example of analyzing the position of placement of temporary anchorage devices. So these are the applications in orthodontics. And this also see there is two lateral incisors, and if you're planning for, depending upon the length of the root canal, you can decide which tooth to extract. So these are some of the little applications in orthodontics. And of course, to know the tooth position, this is an cropped OPG image, and there is multiple impacted tooth, which is hindering the eruption of 1-1. And when in cases like this, definitely with this 2D image, it's not possible to know the exact position of the tooth or which tooth is present. And now with the help of 3D radiology, you could exactly know which tooth to remove, or whether there is an associated odontome, or is there any cyst which is involved with the impacted tooth. And all these things could be easily made out with the help of CBCT. So yes, of course, the main purpose of referral is for impacted canines, to know the position of the impacted canines in the maxilla and the mandible, and to check whether there is root completion or not, and to check whether it is more buccal. In case if you're going for removal, you can check whether it is you have to do a buccal approach or a palatal approach. So all these things. And of course, in case of orthodontic surgeries, you can, as I told you earlier, you can superimpose your image with a facial photograph or the facial structure, and then you can combine the hard tissue and soft tissue, and then you can check for the position, and even pre-operatively and post-operatively also. So these are some of the applications in orthodontics. Now coming into dental implants. Yes, of course, this is the major field where CBCT is thriving really very well in case of dental implants. So in case of dental implants, it is helpful in knowing the bone height, width, and the quality of the bone. So it is that nothing but CBCT is nothing but a 3D topography of the alveolar ridge. Okay, and it is also very, very useful in CBCT derived guided surgical implant surgeries. And it also helpful for assessing the graft. In case you're placing the graft, it's also helpful for accessing what is the whether the graft is accepted, or what is the development, and all these things. It is really helpful. So whenever you're taking why there is a specific implant window in case of all CBCT softwares, and you have to take a transverse section that is exactly perpendicular to the long axis of the tooth. And these kind of sections should not be taken, and this will give you a misinterruption that the width is very large. So exactly this kind of transverse section has to be taken in case of implant planning, to exactly know the thinnest. This section will give you the thinnest with the tooth available with that tooth in that projection. So what will a 2D radiograph give in case of implants? Yes, of course, 2D radiographs will provide you with some information about the height and the mesiodistal width of the edentulous site. Yes, you can make out with this, but is that enough? No, actually, it is not enough to place a implant with a 2D radiograph, and because of course it will give you the width and the mesiodistal width and the height, but the buccolingual width you have to make with the help of 3D radiology. And of course there are different implant ridge types. There can be an undercut ridge, or there can be a lingual concavity. Superficially everything will appear normal, but the ridge, for example, if you see here, there is a labial concavity, but the ridge appears normal here in the occlusal surface. So this kinds of ridge morphology, to differentiate the different type of ridge, and to know the buccolingual width at each and every millimeter throughout the ridge, it is possible only with 3D radiology or CBCT. Of course, there is varied anatomy of nasopalatine canal. So this is a CBCT image showing that different patterns of nasopalatine canals here. So with the help of 2D radiography, you cannot assess that it's not that all the patients will have the same pattern of nasopalatine canal. So it is possible, highly possible, that you're going to perforate and place an implant into the canal itself. So you have analyzing the anatomy with the help of 3D radiology helps us a lot in placing implants. So of course, you have to assess the density of the bone. Density of the bone, as I told you earlier, is it is very, very precise with the ounce field units, which is expressed by the computer tomography. And according to that ounce field units, the density of the bone has been classified as D1, D2, D3, and D4. D1 is nothing but very dense cortical bone. This is a CBCT cross sections, which is showing the different patterns of bone here. First one is a D1 bone, which is a very dense cortical bone, and it is usually present in the anterior mandibular region. D2 is somewhat with a very thick cortex, but the trabecula is somewhat coarse and porous. And D3 has porous cortical and fine trabecular bone, and D4 is mainly present in the posterior maxillary region, and which has very fine trabeculae. And D2 and D3 are the most common type of bone densities that we come across. What is the importance of knowing the density of the bone? Yes, it is important to know how resistant your screws or implant would be when you are placing an implant. The resistance of the bone is much important, so that you will have an idea and the amount of speed that you're going to give to the patient while placing the implant. So this D1 is more than 1250 Hounsfield units. D2 is about 850 to 1250, and D3 is about 350 to 850, and D4 is very less, that is 150 to 350 ounce field units. And what will happen in case of CBC? In CT, we have ounce field units, but in case of CBCT also, there is another system of Hounsfield units based on Hounsfield units, another system which is developed, where group D1 will represent more than 600 Hounsfield units. But in case of CT, it is more than 1250. But in case of CBCT, it is divided as like this. So group 2 and D2 and D3 has 200 to 600 Hounsfield units, and less than 200 it is D4. So this is a classification which we can compare, and we can based on that we can assess the density of the bone. So yes, for ideal implant placement, it is not only in the soft tissue, even in the radiological, you have to make measurements according to this, so that you have at least more than 1 millimeter of bone on the buccal and the cortical bone on the buccal and the lingual side, and the space between the implants should be 3 millimeters ideal space, and the space between the implant and the teeth should be more than 1.5 millimeters. So based on this, the measurements are made in the implant window in the CBCT software. Yes, of course, this is an example of virtual implant placement. If at all, if a dentist needs, he needs to place a virtual implant. For example, if he's placing a Paltop or whatever company you have, like based on that, if you are the particular width and the particular length the implant have, the CB system has all the implant types, all the company implant types, so that we can exactly place that company implant with that particular width and length, and then check whether it is placed properly, and check whether there is any perforations or any fenestrations and dehiscence which is happening, or is it hitting any anatomical landmark and all those things. So virtual implant placement is a more useful tool for the dentist and the radiologist to check whether the measurements are correct. And of course, it is very useful for patient education also. You can even show the patient that this is the implant you're going to place here, this is the size, and this is how it will look. Yes, of course, in cases of angulated implant placements, 2D radiographs will not be helped, because you could see that there is an angulated measurement here exactly at the floor of the maxillary sinus, and of course, CBCT will be helpful in placing the angulated implants. You could see the post-op radiograph here. Yes, this is a window which is showing how the CBCT measurements are done for implants. You're going to make cross sections or transverse section of the edentulous site, and you're going to give how many, according to the thickness of the maybe 1 millimeter to 2 millimeter of thickness of each slice would be of 1 millimeter or 2 millimeter thickness. and then the measurements are given at each and every millimeter distance, the buccolingual width and the height till the mandibular canal. So this is how the measurements are given. This is a buccolingual width, and each 1 millimeter measurements are given, and then the height up to the upper border of the mandibular canal. So this is a window which is showing that basically how we do the measurements. So this slide will tell you of what is implant guided surgery. So first you take a CBCT of the patient, and then you take the CBCT of the patient's model. That is, you take an impression of the polyvinyl impression material, and then you pour the cast, and then you can do a wax up there, and then you can take another impression and prepare a proper model cast of the patient's exact replica of the mouth and the edentulous region, and then you can take a CBCT of the model itself, and then you can overlap the CBCT first and the second CBCT which is taken. There's a separate software, you can overlap it and then prepare a stent. A stent is prepared because you're going to place virtually you're going to place implant and see or it's exact size.
Participants.
Yes, you're going to place stents there, and then the stent is going to you're going to give the stent into a 3D printing machine. You're going to give, and in a 3D printing machine, replica of that stent along with the patient's plate will be made, and this will be kept inside the patient's mouth, and then the drilling will be done exactly. So this is the method of this is a application of CBCT. It is not that only CBCT is needed for this 3D implant guided surgery. Of course, a 3D after CBCT you need a software, a specific software, and a 3D printing machine to prepare the stent that is known as the surgical stent, which will help you or guide you in your implant surgery. And there are also radiographic stents which are present. If at all, radiographic stents are nothing but radio opaque markers. So if at all, if the patient is already wearing a complete denture and you know the exact point of insertion of the implant, you can drill there and you place a gutta percha there and then send the patient along with the denture for the CBCT. The patient will be exposed to CBCT along with the wearing the denture, and then the exact radio opaque markers will be present, will be seen in that radiograph, and we can make measurements around the bone which is present around the radiographic markers. So those are radiographic markers, and these are surgical stents which will be helpful for implant guided surgeries. So I want to show you some of the cases. Apart from implant measurements, CBCT also plays a major role in knowing about the what is the reason for failure of the implant. In case of implant failure, this case was referred because the patient was having constant pain in this angulated implant which was placed, and on taking a CBCT, I was able to make out that there was an anterior extent of the mandibular canal which was the implant was lying on the canal. Maybe the patient was having sensitivity and pain due to that. So this one more case, these are some of the examples of cases where this implant was placed in the, there was periimplantitis and bone loss or pericollision around the implant, and this is implant which is perforating the maxillary sinus, and this implant is exactly placed in the nasopalatine canal, and see in this implant there is contact between the mandibular canal and the implant, which may cause to sensitivity and pain for the patient. So these are some of the cases where post-implant assessment can also be done with the help of CBCT if at all if the patient is having any symptoms. So this another example of case which was placed along the mandibular canal, which is close to the implants placed close to the mandibular canal. In 3D, 3D image, you can easily make out the exact position of the implant and the canal which is in contact with it, which looks really, which is very helpful for us to assess. Okay, now completing with CBCT in case of implantology. Ma'am?
Yeah, Cecilia.
Shall I continue or need a break for 5 to 10 minutes? I don't need a break, ma'am, like if at all, if anybody needs.
No, then no problem. No issues. You can continue.
Okay, okay, thank you. Okay, now coming to the applications of CBCT in periodontics. So main periodontics is bone loss. Bone loss, accessing bone loss clinically, it is the gold standard. But CBCT has shown vast implications in case of periodontics to check for buccolingual bone defects, percussion involvements, and bone destructions. In two-dimensional imaging systems, you will not be able to see bone craters or laminar durant periodontal bone level in limited projection geometry, which causes magnification, and there is superimposition of the buccal side and the lingual side, and you will not be able to exactly know the position of the buccal and the lingual cortical plate, which bone level is less or more. So CBCT in periodontology is of great use. This is a case of cropped OPG where you can see that there is a bone loss here. Yes, of course, this is good, and this clearly shows the bone loss here in between the molars. And this is a CBCT section, which is more precise. In axial section, you can more precisely see the buccal and the lingual bone levels. Yes, so you can also note that there is some interradicular bone loss here in the cross sections. So one more OPG section, which is showing the bone loss, that is a vertical bone loss between the molars. And this is an axial section, which is again showing you the exact extent. You can move the axial sections along from top to bottom, that is from the cephalocaudal region, and then you can analyze the exact amount of bone loss. So this is the bone loss in the anterior regions. So this is implications of CBCT in case of periodontology. This is an intraoral periapical radiograph, which shows mild widening of periodontal ligament space in case of 6, which is present in the interradicular region. Yes, now you could see the CBCT sagittal section. See, there is bone loss. Of course, this will not serve the purpose, and this 3D radiology definitely gives a better picture of the condition of that tooth and the bone loss. So this is an example of a graft placed in the region, and then you can see that you can see the extent. You can easily analyze with the help of cross sections. You can easily analyze the position and the acceptance of the graft by the bone. So these kinds of post graft placement cases, CBCT can be referred. So in cases of measurements of fenestration and dehiscence, CBCT plays a major role in case of measurements of fenestrations and dehiscence, which will not be seen in the 2D radiography, and in 3D view, you can clearly see the extent of the fenestration and dehiscence in case of CBCT. Yes, of course. Yes, of course. Studies have shown that if this is a case, the same case, like it is a root canal treated tooth which is filled, and there's a pocket depth. This is an intraoral periapical radiograph, which is showing exactly there is a huge amount of bone loss. Looks like a periodontal abscess, and see the axial and the 3D sections, which really clearly shows that bone loss levels. And this is a cross section which shows the buccal and the lingual relationship of the bone loss around the tooth. So this is an extra advantage for the patient while referring cases with periodontal compliance. So CBCT studies have shown that CBCT is highly accurate in measuring both horizontal and vertical bone loss defects. There are many studies which have done intrasurgical and during the surgeries, and if they have measured the pocket depth level, and the pocket depth level measured with the CBCT goes, there is 82%, 82.4% of matching between these two findings, that is clinical and intrasurgical measurements of pocket depth level and the CBCT data. So CBCT measurements are as accurate as measurements obtained during surgery with the periodontal probe. So whenever there is an equal, almost 90% of the match between the data obtained by CBCT in case of periodontal problems, and also during with the help of a periodontal probe or clinically or during intrasurgical. So this CBCT plays a major role in cases of difficult periodontal cases where where 3D 3-dimensional view is necessary to decide on the treatment planning of the patient. So there is also some new invention in case of CBCT, that is soft tissued CBCT, which is still under research, but there's a new invention, and which with the help we can also measure the gingival tissue and the dimension of the dentogingival unit, and that is what we were speaking, that is what is a great disadvantage of CBCT when compared to CT, that because we were not able to see the soft tissues, but still soft tissue CBCT is under research, and which will give you a very clear picture of the gingival margins and the facial bone crest, gingival and the cemento-enamel junction, and this is a great advantage. Okay, now coming to CBCTs in oral and maxillofacial. So I've completed with periodontics, endodontics, orthodontics, and implant surgeries. So now coming to pathology, maxillofacial pathology and surgeries. So yes, of course, in cases of maxillofacial pathologies, we come across cysts and tumors and fractures. These three are the very, very main, and of course, impaction cases. So in all these cases, CBCT is of great use to exactly locate the size of the lesion, the extent of the lesion, the relationship to the anatomical structures, the expansion of the jaws, whether to differentiate between benign or malignant, and even in cases of early diagnosis of malignancies because of better spatial resolution, if at all, if you take an IOP and if you come across there is some bone loss in the, which is not very specific of periodontitis, and you suspect it could be a malignant lesion. So in early diagnosis of malignancies, of course, for the position and the relationship of the impacted tooth, and in cases of maxillofacial fractures. So these are the wide applications of CBCT in case of surgeries and pathology. I'll show you some of the cases. This is a case of a dentigerous cyst, which is seen as in IOPA section. Definitely will not be able to make out how big, what is the size or the palatal relation of the lesion. So these cross sections clearly show that there is a perforation of the palatal cortex, which we'll not be able to make out with this 2D radiography. This is a case of malignancy where there was suspected there was a diffuse radiolucency in the lower border of the mandible and the OPG sections, and this is an IOPA. You can see that there is a bone loss, and there's a huge lesion, radiolucent lesion. But on taking the CBCT, you will be able to make out the cortical density and the what is the extent into the cortex and what is the extent into the medullary bone, and you could see the pattern of bone destruction, and also you could see if there's any expansion. You could see mainly you could see the pattern of bone destruction, with which you can decide whether the borders are ragged borders or smooth, or whether the cortex is continuous or is there perforation. So with these things, you can decide whether it is a malignancy or it is a benign lesion. So this is a case of ossifying fibroma. Like, yeah, this is a 2D OPG view. You are not able to make out the expansion here. And this is an axial section where you could easily, there is some thinning of the cortical plate in relation to the lingual side. And you could easily make out there is mild expansion of the lesion. One more case is a cementoblastoma. You could see that there is a huge lesion which is surrounded by a radiolucent rim. Huge lesion which is surrounded by a radiolucent rim, which is very typical of cementoblastoma, but you're not able to make out the extent, and you're not able to make out the position of the mandibular canal, how much the canal is involved. Now you could see that the lesion is expanding. Definitely this expansion we cannot make out in the 2D radiology. So this is a great advantage in case of CBCT 3D radiology. one more case of nasopalatine cyst where the OPG image shows that there is some diffuse radiolucency in the OPG section in the maxillary anteriors, and on seeing the axial and the sagittal and the 3D view, you could make out that it is a nasopalatine cyst, depending upon its position, depending upon its extent, and which was not seen to be odontogenic, because the periodont ligament space and the lamina dura of the maxillary anterior teeth, which were all very intact, and so a diagnosis of nasopalatine cyst was given. So with the help of this OPG image, we'll not be able to make out that it is a nasopalatine cyst because it looks like an odontogenic lesion. Yeah, this is a case of an OKC, keratocystic odontogenic tumor. I'm just showing you the cases to differentiate between the 2D and the 3D view. So what are the information you can gain from a 2D radiograph, and what are the information you can gain from a 3D radiograph? You could the picture itself speaks everything. Like in the 2D radiograph, you could see only a radiolucency here. You are not able to know the extent of the lesion. You are not able to know whether it is expanded. You are not able to know whether it is surrounded by a cortical plate. But in case of 3D radiology, yes, of course, in axial, all the necessary information which is needed for a surgeon to go about with the surgery is present in case of a CBCT. This is a case of dentigerous cyst. Yes, OPG view clearly shows that there is a huge lesion in the posterior mandibular region. But just see the axial section, how much more information you can gain with this images. You could see that there is ballooning expansion of the buccal cortical plate, which is definitely not seen in this 2D radiograph. And you can even measure the lesion, the size, and you can even do cross sections of each tooth. What is the relation of this lesion to each tooth? And in this 3D radiograph, you could see that you could clearly make out the it is as if you're peeling the skin of the patient and seeing the bone itself. It is of very useful to the surgeon to go about with the surgery. Yes, of course, and position of impacted tooth, and odentum, which is hindering the eruption of 1-1. And this was a case which we can easily analyze the position here. But in case of 2D radiograph, it is all clumsy. As you see here, you're not able to see the root of the tooth. You're not able to see whether this is an odentum or whether this is another impacted tooth or whatever it is. Yes, in this 2D section, yes, we are not able to see anything, but the patient was having some pain in the premolar region. The patient was having some pain in the premolar region constantly, but nothing was seen in the 2D section. Yes, I could able to make out some amount of radio opacity here between the premolars, but it was not that evident there. On the sections, it was noted that there is a developing supernumerary tooth. So maybe that is causing the pain for the patient. So these are some of the advantages of three-dimensional radiography. Yes, of course, the main reason for referral by a surgeon to a CBCT center is knowing the position and the involvement of the canal with that of an impacted tooth. The canal can either be drifted downwards, or it can be present between the roots, or it can be present more lingual, or it can be present more buccal. So these cross sections give examples. You can see that the canal is present more buccal, and the tooth is impacted more lingual. And so to know the exact position of the mandibular canal with that of the impacted tooth, CBCT is of great use. So in this three-dimensional reconstruction, you could see that the canal, how it is traveling into the root. So this is of great advantage to the surgeon while removing an impaction tooth. This one more case of osteoma. Again, it is the same thing where it definitely CBCT sections. This is an OPG view. I think you can make out that there is a radio opaque lesion here, but seeing the OPG view and the 3D rendered view, you could make out that there is a radiolucency surrounding this osteoma, and you can make out the buccal and the palatal relationship. This is a case of periapical cyst where, yes, with the help of the 2D radiograph, you will be able to make out that there is a lesion, but definitely this amount of root resorption, which is seen in this cross section, I think I'm not able to make out any root resorption here. Maybe it is present, but it is superimposed. But in case of 3D and the cross sections, you'll be able to make out the root resorption and the expansion of the lesion. Yes, that is completing with applications of CBCT in surgery. Now coming into CBCT in sinus and ENT pathologies. Yes, of course. In cases of maxillary sinuses, the applications of CBCT was vast in recent times during the COVID times, where the patients, where there's many cases of mucormycosis, and many of them, most of the cases represented itself as periodontal lesions in the tooth, involving the tooth, along with maxillary sinusitis. Yes. In cases of sinus expansion or displacement of the walls of the maxillary sinus, destruction of the bony walls of the space, and thickening or hyperostosis of the walls surrounding the space of the sinus, or a pan-sinusitis, that is, you can also see the ethmoidal and the sphenoidal sinuses with the help of CBCT. You can also see for nasal septal deviations, tonsilolith or concobullosa. All these are ENT sections, but still we'll be able to make out all these things with the help of CBCT. So this is a case where there was some periapical cyst associated with the 26, 25, and 26, and on seeing the CBCT sections, we were able to make out a thin radial opaque line which was into the sinus, which is maxillary sinus cyst, which was involving the maxillary sinus, and apart from that, there was associated sinusitis also. Yes, this is one case of fungal osteomyelitis, or otherwise called as mucormycosis, where there were so many other cases which was referred for CBCT, and most of the cases where we were able to detect, because most of the cases were not rhinocerebral forms, because it was first involved the alveolus and then it involved the maxillary sinus. Of course, the rhinocerebral forms we will not be able to make out, but when it is rhinomaxillary form, definitely dentists play a major role in diagnosis, of course, in clinical diagnosis also, because it presents exactly as a periodontal lesion with when there is mobility of the teeth and periodontitis with pus discharge. Of course, before even the palatal ulcerations, which is formed, which is very evident even before the palatal ulcerations. Earlier to the palatal ulcerations, you would see the periodontitis and the involvement of the sinus with the help of CBCT. And of course, you will be able to, it will be helpful to see even the ethmoidal sinuses, frontal sinuses, and the sphenoidal sinuses with the help of CBCT. It's a case of, you can see osteoma of the ethmoidal sinuses and osteoma of the frontal sinus. So these some of the examples of sinus cases. This is a case showing tonsilolith These sometimes it can be an accidental findings. Of course, it is of ENT's interest, but still, as oral radiologists, we would be able to make out all these if we are taking a full facial for some other purpose. CBCTs and sinus pathologies. This is a case one where there was a lesion in the sinus because of odontogenic origin. There was a missed MB canal, mesiobuccal canal, which is causing recurrent infection, and it causes acute sinusitis. These kind of air bubbles, air trapped inside the sinus, indicates acute lesion or acute infection. And there is elevation and perforation of the floor of the maxillary sinus. So these are some of the applications of CBCT in sinus pathologies. Of course, these are some of the outward cases, like where yes, like cases where you can see even osteophytes in the vertebrae. So these are accidental findings. I mean, definitely patient not be referred for CBCT for an osteophyte in vertebrae, but some of the things where we also have application apart from dental root. This is a case, a very interesting case of multiple impacted molars. There were 3 molars on the left side, and there are extra molars on the left side, and 3 extra molars on the right side, which was impacted. Totally, there were 6 molars. So this case was diagnosed as Gardner syndrome. So this definitely then OPG, which if you have viewed the OPG of this patient, definitely so confusing, because like we really don't know how many teeth are impacted, what is the position of the tooth, whether the root are completed or not, whether it is associated with any lesion, what is the bucco-palatal position, and all those things. CBCT plays a major role in such cases. Yes. Next, coming to CBCT in temporomandibular disorders, which is of great interest as an oral physician myself. It provides great measurements, accurate linear measurements of the TMJ, and of course for all the osseous changes, erosions, early osteophytes, degenerative changes, condylar changes, or fractures, if there is a bifid condyle, any osseous change. When you think of CBCT, because it is more precise and it is really has a very high resolution. And apart from that, whenever you suspect that there is a soft tissue involvement, or there is a disc displacement, you call it as anterior disc displacement or posterior disc displacement involved, you go for an MRI, because MRI gives you a better image of the articular disc, because it is a soft tissue. Of course, there are some findings of the osseous changes which can make you suspect that there is an internal derangement. But still, when you really want to view the soft tissues, go for MRI. Apart from that, all the osseous changes you can make. See, in this case, you can see that there is a reduction in the articular space, articular space, and this you can see a radiolucency in the subchondral region, and this is cyst, subchondral cyst, or you can even note an osteophyte formation. See, all these are erosive changes, and the cortex is there is erosion of the cortex here. All cases of osteoarthritic changes you can easily make out with the help of CBCT. It's a case of rheumatoid arthritis, where you can see that there is erosion and there is also their cortex is not continuous. There is some subchondral cyst. There is a change in the shape of the condyle, and these are all osseous changes where you can see rheumatoid arthritis, early juvenile arthritis, osteoarthritis, inflammatory arthritis, and these are some of the applications of CBCT in case of TMJ, if the patient is having TMJ pain. This is case 1 and case 2 of juvenile idiopathic arthritis. You could see that there is an alteration in the shape, and you could see that there is also some flattening of the articular eminence here. The articular eminence is not fully, there is flattening and resorption here of the articular eminence. The cortex is not continuous, and this I'm just showing you these cases to just make you familiar with the applications of CBCT if the patient is complaining of a TMJ pain, or if there is a TMJ fracture, it's an TMJ intraarticular fracture. You can see a fracture line here. So these are some of the examples of applications of CBCT. This is a case of bifid condyle. This is a cropped OPG image. I could not see there is a bifid condyle here, but on seeing the CBCT sections, you can easily make out that this patient was having chronic TMJ pain and chronic dislocation of the TMJ very frequently. So these 3D view will also give you the very clear picture of the osseous changes. There is subchondral cyst and there is erosion here, which is very clearly seen in the 3D view also. This is a case of synovial chondromatosis. There is some radio opacities in the articular space here. So that has caused the condyle to move downwards and forwards. So this is also all these kinds of osseous changes. These are all whatever I showed now is osseous changes, which will be very clearly seen in the with the help of CBCT. This is a case of I'm just showing you that this is a case of internal derangement, that is anterior disc displacement. But I'm not, you will not be able to see the disc here, but usually in cases of anterior disc displacement, the condyle will be placed a little posteriorly. So with that mark, here the condyle is placed more posteriorly, and during the movement also. During open mouth movement also, the condyle is not that forwards. No, it is not fully forward. So with this movement changes, you can suspect an internal derangement. Of course, you cannot confirm it. You have to confirm it with a higher radiographic images. Next, coming to the airway analysis. Yes, mainly you have to check for the tonsils and adenoids in cases, or a pre-assessment for before an orthodontic surgery. So this is the nasopharynx, oropharynx, and the velopharynx, where you could see that this space here, this is the airway space, whether it is constricted or not. So to check for constrictions, you can take a CBCT. There is a separate airway analysis tool which gives you color coding. You can mark the airway space, and it will give you the airway space in the color, and it will give you the exact thickness of the airway space at each and every level, so that you can analyze the thickness of the airways. This is a case where it's showing there is an enlargement of the adenoids here, so that there is constriction of the airways here. So this is the airway analysis tool I'm showing you here in this software, where you can mark the airways and you can see the thickness of the airways. You can see the airways along with any section. You can see it along with axial section, with sagittal or coronal, or you can even see it in the 3D section, or without any section. You can exactly take only the airway and then you can analyze it. So there are different views present. So coming to applications of CBCT in caries, no, it's a great no. It cannot detect caries. Intraoral periapical radiograph is the best radiograph of choice in for operative dentistry. So you cannot refer a patient to check whether there is dental caries or not to CBCT. Yes, finally, I'm concluding. Thank you so much. So CBCT is really a very high imaging or very high useful modality, indispensable part, really playing an indispensable part in dental imaging armamentarium. But it all depends on how we use it wisely. So thank you so much. I thank one and all present here for the opportunity given. I thank all the participants here who listened very patiently, and I thank the organizing team, Dr. Balan sir, Dr. Gopalnathan sir, Dr. Sudhamani madam, and of course my sincere and my special thanks to Dr. Raj sir and Dr. Yasmin sir, who are my seniors. Like, it is a really very touching moment to present in front of your seniors. And a very great thank to the other staffs who are present in the department also. I think Dr. Aravind, and I'm not very familiar with the names. So thank you, the organizing team. Thanks for the opportunity, and have a great day.
Thank you, ma'am. It was a very extensive lecture and it was very elaborate. I'm very sure your lecture will help a lot in understanding the conceptual applications of CBCT. There are a few questions in the comment box, ma'am. Shall I read it out, ma'am? Ma'am, am I audible, ma'am?
Yeah.
Yes, ma'am. Ma'am, first question is that when planning implant in one segment, for example, 1/6 region, is it possible to take a CBCT of 1/6 alone?
No, you cannot take it only for 1/6. It will be for 2 or 3 teeth involved, like
Yes.
1/6, 1/7, 1/5, 1/4. Yeah.
Yes, ma'am. Ma'am, next is that presently, which is a better machine available for dental structure, better CBCT machine?
I think I'm not the best person to answer that question because I have been working with only casting software, and where I went for to learn CBCT also, it was a plan mecha mission. Yeah, it was good, and I have been used to casting software, so I would tell that casting is the best. But still, there are many missions available, depending on and cost also matters.
Yes, ma'am.
Okay, now there are many missions which have come with very cheaper and with all the facilities, whatever I have told you. So it depends, like depends on your choice. If it is a college setup, it is different. If you are going to buy it for your personal clinic and personal purpose, then I think you have to go for a cheaper mission with lower FOB. So it depends upon what the need is.
Okay, ma'am. Ma'am, next question is that is there a particular format for CBCT interpretation and reporting?
No, actually, there's not a particular format. It's a format what you develop by yourself. Like if you are a reporting radiologist, then you have to report by yourself. There are many formats available in the Google.
Yes, ma'am. Okay, ma'am.
But there is no particular format. There's no particular format.
Okay, ma'am. Ma'am, next, how to distinguish between hypercementosis, localized bony enostasis, and odontomes?
How hypercementosis, it will be associated with the apex of the tooth, right?
Yes,
yeah, it will be associated with the apex of the tooth, and there will be in case of odontomes, there are complex odontomes and compound odontomes. In case of complex compound odontomes, maybe some it will resemble the tooth structures, some, and it will be multiple in number, and it will be surrounded by a radiolucent rim, and it will be well defined. In case of complex odontomes also, it will not resemble the exact tooth structure, but still you can make out. And what is the other one? Cementosis. Hypercementosis is usually associated with the tooth. You can see that there is, you call it as a bulging of the root, apex of the root.
Okay,
Yeah,
ma'am.
then.
Ma'am, next question. Will the soft tissue CBCT be superior to OCT? If so, how, ma'am?
Soft tissue CBCT, still there's no literature available for soft tissue CBCT. It is still under research. So it will be superior to CT because of course, when we also include soft tissue, the radiation is going to be more, but definitely not as much as CT. When we incorporate soft tissue CBCT, like yes, definitely it will help us more and it will aid us more in our diagnosis and treatment plan.
Yes, ma'am. That's all, ma'am. The questions are over, ma'am. Now,
Thank you.
Now, I would like to call Dr. Yasmin sir to present the certificate of appreciation to Dr. Cecilia Subbulakshmi ma'am.
Good afternoon, everyone. On behalf of Department of Oral Medicine, Vivekananda Medical College, I would like to thank Dr. Cecilia Subbulakshmi, who was my postgraduate junior, for accepting our invitation. And at this juncture, I would also like to thank Dr. Mohan sir for joining this presentation. I know that it would be a big surprise for Cecilia, being Mohan sir as a spectator for your presentation. And coming on to the presentation, Cecilia, it was a very good extensive presentation actually. And your presentation was a complete overview of the subject CBCT from the basics to all its clinical applications. I felt the highlight of your presentation was a demonstration of case of your personal experience actually. And I personally, I was reminded of our postgraduate days. And the only thing missing here was the question session from Dr. Mohan sir. And if you are willing, we can ask sir to put up some questions also.
I hope sir will not put me into trouble now.
It was a big nostalgic moment because we being a part of this presentation, me, Raj sir, Aravind, along with Dr. Sir,
It
Mohan
was,
sir also.
sir, it was more like a seminar to me, like all are present, even HODs present.
Yeah,
So this was like a
yeah, I felt the same. Me being a spectator and you presenting, and sir being a spectator also. So kindly accept our token of appreciation, and I wish you many more laurels in your future. All the best, Cecilia. It was very good presentation.
Thank you, sir. Thank you, ma'am. Now I request Dr. Aravind Raja, sir, to deliver a vote of thanks.
Good afternoon to all. On behalf of OMR department, VDCW, I hereby extend my grateful thanks to respected chairman, Dr. Karnadji sir, for providing the platform to providing the CD program, and Dean, Dr. Captain Dr. Gopalnath for the guidance and support, and Principal Dr. Balan for helping us to conduct the successful CD program. And thanks to Dr. Sudhamani ma'am and Dr. Shivaram sir and Yasmin sir and Ambika ma'am for this support in the CD program. And special thanks to all the HODs and staff members of all the department of VDCW, and special thanks to Dr. Mohan sir for the valuable presence in the CD program, sir. Thank you, sir. And special thanks to Dr. Cecilia ma'am for the wonderful lecture on CBCTs and these applications. And thanks to Dr. Ganapati and Mr. Purushothaman for their guidance and support for this CD program, and Mr. Shakti for the technical support. And last but not the least, our thanks to all the UG students and PG students and all the participants for this patience listening and making the serious program as a successful program. Thank you. Thank you, ma'am. Thank you, Cecilia, ma'am.
Thank you, Aravind.
Thank you. Pavitra, questions?
Ma'am?
Yeah, Dr. Cecilia. Yeah.
Yes, ma'am.
It was a very good learning experience for me. I have learned a lot from your presentation. It was a very elaborative and extensive presentation. Actually, we have planned 2 different sessions, a basic part, 10 minutes break. I think it's very difficult for you to have a continuous. Actually, it is almost a 2-hour session. You didn't have a break of a minute also. Next time we'll plan accordingly to have a break and continue. But it was a very informative, a good learning experience for me. Thank you, Dr. Cecilia. Thank you. Thank you so much.
Thank you, ma'am. Thank you so much for the opportunity.
Yeah. Shall we wind up the session?
Yeah. If there are no further questions, like we can wind up.
Ma'am, that's all, ma'am.
Yeah, fine. Yeah. Yeah, fine.
Yes, ma'am.
Thank you. Thank you so much.
Thank you, ma'am.
Thank you, ma'am. Thank you so much.
For the participants, I have posted the feedback link. You'll get the e-certificates within 2 days. Thank you. Thank you, one and all.